Okay, we'll get started. Good afternoon. It is my sincere pleasure today to introduce our grand round speaker, Dr. Savitri Fedson, who is speaking on living and dying with an LVAD. So many of us here know Dr. Fedson, but for those of you who do not know her, she is professor of medicine and clinical ethics at the Michael DeBakey Houston VA Medical Center, where she founded the Advanced Heart Failure Program and the Heart Transplant Program. She's also a faculty member at the Center for Medical Ethics and Health Policy at Baylor and serves as the co-chair of the Ethics Committee. She completed undergrad at University of Chicago and obtained a master's in intellectual history. She also went to medical school at UVA and completed residency and fellowship at University of Chicago, where she was the chief resident. She completed her advanced heart failure training at the Brigham and is also a graduate of the McLean Center for Clinical Medical Ethics at the University of Chicago. She is very well known in the advanced heart failure and transplant field, having been involved in patient care for over 20 years and actively involved in ACC, ISHLT, and all of the societies, and contributing to national practice guidelines. She currently heads the ABIM Board Exam Writing Committee for Advanced Heart Failure and Transplant. So there you go for those of you taking boards. And her interest in the ethics of scarce resource allocation and the intersection of individual autonomy and public health have earned her high status as an international and a national speaker. I also recently discovered that she has participated in the training of several of our colleagues here. She's a mother, she's a baker, and I discovered has a surprisingly extensive knowledge of bees. So without further ado, I present to you Dr. Fedson.
Thank you, Monica, for that introduction. And we had a lovely dinner last night, and we did indeed talk about bees. And it's really nice to be here. I've only been to Ann Arbor a few times. I did come once just to see the peonies at the Arb, which are beautiful. And my mother actually came here when she first moved to the States from India on a Fulbright. So she is a Wolverine, so it's sort of nice to be back here. And so thank you. And I took the liberty of sort of taking a little different spin on the talk about ethics of organ allocation, because I wanted to talk about some of the different consequences when we think about how we create organ allocation policies. So please forgive my little sort of leeway with the interpretation of that talk, but I will talk about how that affected how we talk about patients who are supported by LVADs. Okay. I don't have any disclosures at all. And I will really talk about this in four sort of settings. First, why we consider, when we consider MCS, what it's like to live with MCS. And I'm really just talking about LVADs. This is distinctly not really addressing people with total artificial hearts, which is a different ethical quandary. I'm going to talk briefly about futility and how we approach that, and then our dis-ease with talking about those with chronic disease, and how that's different and how we need to think about it differently in our field. So why do we give people MCS? What do we think about, and what is the reason why we implant people with durable LVADs? And I think, many of us would say it's to sustain life. And if we think about, picture it here, like what we typically think about life-sustaining treatments. We think about ventilators, we think about maybe artificial nutrition, hydration, we think about dialysis. But I think in cardiology, we have to extend that a little bit because there are a lot of things that we do. So pacemakers are a form of life-sustaining treatment, as distinct from a defibrillator. So I think we as a group, have to think about the interventions we offer patients and sort of implant in patients and how that's different. So we want to sustain life when we give people an LVAD. But I think it's also, we really want to improve their quality of life. I mean, that's why we're doing it. So there is a difference, and I talk with patients about either just existing or actually living. And as a patient I met years ago in Chicago came up to me, he was, full of bluster and trying to minimize his symptoms. And he was sort of like, you are here to bring life into my joy. And that's what he wanted us to do. He wanted to have a better quality of life, and that's why he wanted and eventually got his LVAD. So I want you to keep that in mind as I talk about what it's like to live with an LVAD and necessarily what we have to be able to afford patients when we engage in conversations with them. So going back briefly to think about life-sustaining treatment, most of the time we really think about it in the ICU. And most people, most primary care doctors don't think about having conversations about life-sustaining treatment. I would argue that many of them should. 60% of deaths are a consequence of chronic conditions, and therefore the best place to talk about that is actually the outpatient setting. So in the ICU, and CID is cardiac implantable electronic devices, and MCS are what we think about in the short term and in the ICUs. But I think what we have to realize is that we have a lot of community dwelling life-sustaining treatments. So there are more people living with pacemakers in the US than are supported by outpatient community dialysis centers. So there are more people out there with life-sustaining treatment for cardiac reasons than there are for renal replacement therapy. And typically we think of dialysis as being one of the forms of life-sustaining treatment that we always talk about discontinuing in the ICU, realizing that that's not really the case. And then of course we have VADs, which are a form of life-sustaining treatment. And the whole point of them is so people can live outside the hospital. They could go travel. They could live in the community. They could have essentially normal life. So I think we have to think about how we address these discussions about life-sustaining treatment, which are, I don't want to say mundane, but they're rather banal and they're invisible to many of us as people are existing in the community. And I think we have to be cognizant of what that necessarily means when we talk about end of life and actually the sort of lifespan of any of these devices. So with that in mind, I want to talk about what it was like or what it is like to live after VAD after 2018. And why 2018? And this is where sort of the organ allocation system comes in. And I'm first going to talk about survival with an LVAD. So these are data, the most current era is going to be in the green line. And these are looking at historically the first rematch. So the first rematch pulsatile LVADs. So what got FDA approval for destination therapy? The VADs were good, survival benefit, but the machines failed at about 18 to 20 months. Since then, over the last 20 years, we've had amazing technologic developments, improvement in the biology interface between machine and sort of the human biologic parts, so that now at about 5 years, we have sort of real life experience, 60% survival with LVADs. That's great. Realizing medical therapy that probably have a 20 to 40% survival. So clearly improved survival. If you look at the graph on the right, what you have is competing outcomes. Again, if you look at this is the contemporary era, so it's after 2019, but these people were implanted prior to 2018, most of these. I think it's important to realize that you have about 40% are still alive on a device at 4 years or 5 years. But I want you to look at the fact that you also have about 40% of people have died on the device. So as many people are living with the VADs as have died on the VADs. These are not people who got explanted for transplant. So we have to realize that as these lines will merge and eventually more people will be dying with a VAD than surviving with a VAD, how does that happen and how do we think about it? And it's important because technology certainly has improved over the development of VADs over the last 20 years. We have technological improvements. We have fewer complications of certain types. We have fewer pump thromboses, absolutely fewer strokes. But there are still complications that we know will happen. We know people will develop driveline infections. 40%, 25 in the first year will have a driveline infection. We know that people will have GI bleeds. It's less than it used to, but people will have GI bleeds. They will have so GI bleed, driveline infection, they will have some degree of strokes, but right heart failure, we've still not managed to appreciate who's going to be at risk for that, who will have it. These are anticipated consequences that are still happening. And if you look at the graph on the right, these are still, if you look at the yellow, the orange and the black line, these are in the momentum pivotal and the momentum trial. GI bleeding still is happening more so than sort of late intermax. These are not insignificant consequences. So we know that people are getting VADs. They're going to have these consequences. We know we have to talk about it. However, they're better than they used to. What I think is important to look at, and this is where when we think about the effect of the allocation system, is that the number of people who were transplanted as bridge to transplant has decreased, and the relative number of people who are getting durable therapy or long-term therapy has increased. Therefore, we need to think about the ramifications for that. And how are we best to deal with those situations? So what was the allocation policy? For those who are not sort of immersed in the allocation policy of transplant, prior to 2018, so the last revision prior to 2018 was, a decade plus before that. But in 2018, prior to 2018, we basically had three categories of allocation for transplants. Status 7 remained the same. Those are people who are inactive, not gaining time, nor are they losing time. They are not eligible for an organ allocation for whatever reason, infection, travel, whatever reason. Then you had status 1 and 2. 1A was classified into 1A or 1B. These are people who were mechanically ventilated on inotropes with a SWAN, different categories. And then status 2 was medical management, oral medical management. And because of a number of things, one of them being the improvement in mechanical circulatory support. So people realized the risk of living with mechanical circulatory support changed. People supported with LVADs were doing better. There was a big decision and undertaking to change the allocation policy to make the first 1A, 1B status much more granular. And the idea was to make sure that the sickest patients got transplanted, achieve priority, to decrease death on the waiting list, and to actually improve the geographic equitability or allocation for transplants. So that was the intent behind it. So most VAD patients, stable LVAD patients, would be 1B category. But what they did after 2018 was they basically took those two groups and divided it up into 4. And so what you now have is much more granular information about people who should be sick. And the whole idea was that people who are the sickest, who you anticipate will not survive more than 2 weeks, should get organs allocated first. We want to decrease waitlist mortality. We want to improve survival. So only those people who are on ECMO, for example, they aren't going to, after 2 weeks on ECMO, you're going to start having complications which will impair someone's ability to get transplanted. These are the people who should get allocated first. Then you have people on balloon pumps and Impellas. Again, those are designed as short-term devices. They are not designed to be long-term devices. These are the people who then should get allocated first. So you look at where LVADs fit into this, and the stable LVAD after 30 days is a status 4. So of the highest priority, which used to really be 1 status, there are now 4, and LVADs, the chronic LVADs, are at the bottom. Now, there is what's called discretionary time, which is that any time someone gets an LVAD, you have 30 days where you're allowed to have slightly higher status. And this really goes back to an old period of time where they used to sort of give people credit for taking for having undergone another operation. I think it was the early teens, it changed. It used to be 30 days right after the operation, which made no sense to people practicing clinical medicine because that's when you needed people to rehab and get their strength back and gain muscle mass. So I think in the early teens, they changed it so you could have that discretionary period of time at any point. So you could, 6 months when you got, you've recovered from your cachexia, from your heart failure, you could get that higher status. So we still have that where it's now a status 3, but basically what it meant is that VADs who used to be able to get higher priority for organs now dropped down significantly in the organ allocation system. So how did that affect living with a VAD? So it had some unintended consequences. Some of these probably were foreseen, but not really thought through, I think, to the extent that they needed to be. But we did have higher priority status and listing. And unfortunately, with that, we had more use of ECMO and Impella balloon pump so that people who might otherwise have been managed otherwise, in order to make sure that they would get their allocation in a timely manner, people, and I was talking with Dr. Aronson this morning, people do game the system, unfortunately, about trying to support people that may not need it. They've changed this a little bit. They're now shock criteria, so hemodynamic criteria we have to use. But I think in general, sicker people were getting transplanted earlier, but what that did to VAD patients is that the rate of people who were implanted as a bridge to transplant decreased from 35% to 20%. It actually decreased the 1-year survival for people who are getting transplanted off of LVADs. Their 1-year transplant survival worsened. If you have renal disease, it was even more so that's the graph on the right. So if you had CKD3, and you have an LVAD and you get transplanted, your survival is worse. Add to that, now we have a safety net kidney program, so fewer people are getting simultaneous heart kidneys. That's going to add to the survival as the decreased survival as well. And the use of bridge to transplant LVADs has decreased. I think this is shown most clearly in this slide, where you have clearly the number of people who are listed with an LVAD and not changed after 2018. This clearly changed, so that after 2018, only 20% of patients being implanted with a VAD were being implanted as a bridge to transplant. So the organ allocation affected the number and the types of people we're listing with VADs. What it didn't address is the people who were implanted beforehand, the people who were implanted as a bridge to transplant perhaps in 2017 or 2016, and the effect it had on their life and living with a VAD. If we look more now at what's happening, these are the LVADs as bridge to transplants. So in that waiting time now, 30% of people who are listed and bridge to transplant with a VAD lose their eligibility for transplant. It may be because they develop right heart failure that is refractory, maybe that they have a catastrophic bleed. For whatever reason, it may also be that they're just 6, 7 years older now. But 30% of people who are listed or bridged with the intent to list are no longer going to be transplant candidates. So they're fundamentally a destination durable LVAD therapy. And so I think we have to figure out what that might mean for those living and the expectations. And we have conversations about implant. How are we going to approach that? Now, the 80 of the 3,200 people now waiting for a transplant, this is a snapshot right now of how many people currently listed for transplant actually have durable LVADs. And it used to be a significantly higher portion than 2.5%. It used to be easily 30% of people were supported with durable LVAD therapy. But I think this is important because there's been a proposal to have a policy change at the end of this year, which gives credit. So they're realizing that having a durable LVAD, and if you're planted as a bridge, that no longer helps you. And at a certain time, certainly the complications that we know will happen, there are known foreseeable complications, most of them will happen by the time you're supported with a VAD for 6 years. So those would be driveline complications, right heart failure, GI bleeds. Most of those will happen by 6 years. So there's a proposal that may come into place at the end of this year that says if people have been listed for 8 years, they will automatically be able to be listed or have their status listed to status 2. So they will more likely to get an organ allocation. They're more likely to have the complications of durable LVAD, which may not be the life-threatening complications now, which give people a higher status. Certainly if you have incessant VT, if you have intractable RV failure and you need an inotrope with your LVAD, that counts as failure. If you have wide open AI, that will count. Although now that we're doing trials of basically TAVRs that don't require calcium, we may be able to address the AI associated with durable LVADs, so that may lose its ability to have an exception. Yes. That was just when they sort of looked at the authors of the paper looked at it at that point and looked at the number of people. For which, I'm sorry, the 30% of people losing? It was not at any particular time of year. So it looked at those people waiting over support and how many listed supported with the VADs ultimately were able to achieve transplant or conversely were delisted at some point. So it didn't specify what period of time after VAD. So that's sort of how organ allocation changed living with a VAD. And so we have to think about, as people live with a VAD longer, what that means. And this comes with the whole idea of the ontology, or the perception of experience, and what that may mean, what it's like to live with a VAD. You have to carry around 3 to 4 kilos or 10 pounds of equipment all the time. You have to go through sort of shenanigans to take a shower to make sure your driveline doesn't get wet. You have to self-test every day. I work at a VA. Many of my veterans have PTSD that's triggered by sound. So if every day you have to have your VAD make a pretty horrible sound, what do you have to do in order to prepare them to do that every day? So their PTSD isn't triggered every day by their self-test that they need to make sure that their VAD is functioning. These are what it's like to live with a VAD. These are the inconveniences that go along with the improved quality of life. Now, Husserl and Ponto-Muslo are two philosophers who've looked at sort of perceptions of being and experience of being. And I think they present a very nice argument which has to do with transparency. And for those of you who wear glasses, you could think about it as most of the time you don't know you're wearing your glasses. In fact, you may try and look for your glasses and then you go like this and you realize they're on your face. And you don't realize you're wearing them until you forget to take them off when you go in the shower or you go into a warm room and your glasses fog up, at which point they become opaque, they get in the way, they affect what you're able to see, and they become burdensome to you. And so that whole idea of what is transparent or what is burdensome or opaque has to do with how we perceive whatever tool we're using. And I think that's a useful way to think about LVAD support. At what point does it become burdensome? At what point does the existence of living with an LVAD get in the way of actually living with an LVAD? So this is, I think, an interesting way that we need to think about how we talk and how we manage patients with chronic LVAD support. Because while patients do better, functionally, we know they do better. These are data looking at 6-minute walk distance, New York Heart Association class. Clearly, patients have improvement in New York Heart Association class and 6-minute walk distance, typically by 6 months. That lasts out to 2 and 3 years. We know that with the earlier HeartMate 2 devices, certainly now with the HeartMate 3 and the other sort of maglev devices we have. We know that. So this happens. 6-minute walk distance can improve and be sustained out to about 3 years by 200 meters. That is a clinically significant difference. It's not just statistically significant, but walking 2 football fields is a big difference. That means you could become a community ambulator. You could cross the street quickly enough that the white man flashing doesn't turn to red. You have to be able to walk a certain speed in order to do that. You could be a community ambulator with this. This is an important thing. However, in all of the VAD studies we have, and this is the momentum, these are multiple trials, 30% of people with LVADs don't live well. It's called failure to live well with a VAD. And this comprises not only those people who don't have the physiologic improvements, who aren't able to achieve a significant improvement in their functional status, just physical functioning, walking, ambulating, but also takes into consideration a significant amount of the emotional stress and burden, the psychological burden of living with an LVAD. And a low quality of life in that respect. So I think it's important to realize that we have, even in the current era where we have very good success, and I support supporting people with LVADs, we have a third of those patients who don't achieve what we hope, which is not only to sustain life, but improve their quality of life. So these are data from 2 groups, one in the US, one in Australia, looking at the psychological outcomes and sort of quality of life measures in patients who are supported with LVAD. And these are, it's a sort of a conglomerate of patients. So it's anyone who's survived hospital sort of discharge after their index hospitalization, but it's at any point from a month out to a number of years out after LVAD implant. So you have people who both have that improvement up to the sort of 6 months and then maintained out to sort of 2-3 years, and also people who have been sustained later. And I'll get into that a little bit about why it's important to look at the tail ends. But 10% of these patients so different societies, the US and then Australia, rated their health as being the worst imaginable. 12% had suicidal ideation. That's consistent with French studies that have looked at people supported with LVADs. Significant number of them have psychological stress and burden. It has to do not only with their own psychological stress and burden, but the feeling of imposition upon their caregivers and loved one. And that's not a trivial amount if we think of we're giving someone a therapy and they've got a 10% chance of having suicidal ideation. That's a pretty significantly high number we have to think about. And I think it's important to think about the longer duration, because while we have that wonderful increase in the first couple of years of functional quality of life, we have fewer data, although they do exist, and I could certainly show you later, but in the more recent sort of analysis of momentum looking at 5 and 7 years out, at about 5 years, you start having a decline in functional status. So while you have an increased uptake, at some point your functional status starts declining, your 6-minute walk distance starts declining. There are few data that look at it. You could look at the supplementary data, which is typically where we find these outcomes, but the increased benefit we have in quality of life with VADs is not, it doesn't achieve a plateau and sustains there. That's not to be surprised. People are getting older. At some point, your age merely will allow you to have some functional decline. We have to recognize that. But these are all comers, even people implanted at 30s, 40s, as opposed to the geriatric population. So we know that at a certain number of time, at 3 to 5 years, the functional improvements that people had with LVADs starts declining again. And we haven't done anything really to improve the psychological stress. We've done a really good job at perfecting the mechanics and the engineering of the pumps. Save the driveline, we're still working on that. But the other stuff we haven't dealt with yet. So at some point is the promise that we've given of saying, this is a great device, this is going to help you. At some point, is it really not what we're promising? Is it not reality anymore? And people have always talked about, the bridge to nowhere. And I think that's a different, I think we could think about it a little bit differently, because when we bridge people with an LVAD, we have an intent. Our intent is either durable therapy or recovery, perhaps, and maybe the 10% who will recover, or transplantation. This is the same with any type of life-sustaining treatment, I would argue. We have to think about why we're doing it. So this is a bridge in Honduras, and it was re-engineered and designed because they knew at some point they were going to get a hurricane. And they wanted to build a bridge that would sustain the hurricane. And they really spent a lot of time replacing the old bridge with this new bridge. And so what happened? The hurricane came, and it was a bad hurricane. And the bridge did it what it was supposed to. The bridge withstood the hurricane. The river changed. The hurricane literally moved the course of the river. And I think that's the way to think about when we think about these devices. What happens if the device is still working fine, but everything else has changed? And how do we think about it at that point? This is, I think, when we get into discussions of futility and what is futility. And when I mention that word, it's sort of the F word in medicine. All of you probably have a different thing that comes to mind about how you think about it. And I think it's important to sort of tease it apart a little bit. I think it's a word that's often overused, I think often misused, and is associated with a lot of value statements. So I think it's important to break it out in what we mean. And the ethics literature has really taken this into 4 views of futility. And the argument now where the move is really to talk about inappropriate medical care as opposed to the term futility. I would argue that futility should never be paired with care, because care is never futile. You could be in a futile treatment, but caring is always the appropriate thing to do. But if you think about how we look at that term futility for what it is, the first 2, physiologic and imminent demise, are what we see typically in the ICU. I think this is easy to sort of understand. Physiologic futility, for example, ECMO will not help someone in fulminant liver failure. That is not what it's designed to do. There's no physiologic purpose of doing that. Imminent demise futility would be persistently coding someone with a pH of 6.2. It's not going to work, right? They're going to die irrespective of what we do. So I think these are things that are easy for people to think about. Sort of there are clear, biologic, serologic markers that we could use to define the success or the ability of something to cover therapy. However, it's the last 2, the qualitative and clinical futility, that we struggle with as a community. And I think this is because it's focused on values. And we have to remember that it is not our values that we need to be considered. We need to consider the values of our patients. It is their values, their interpretation of quality of life that we need to respect. And functional qualitative futility is where the treatment can be effective, but is going to be leading to a decreased quality of life for that person. Examples to think about: if you have someone who is a food critic, the idea of getting a PEG and not being able to eat might be an unacceptable quality of life for them. Someone who has to give up living at home because they have to go on hemodialysis and they don't have the transport, so they'll have to live in a facility. They don't want to do that. That may not be worth it. So that's a functional qualitative futility that we as providers can't judge. That's solely within the purview of a patient to decide. It's when something becomes too burdensome for them. This is, when your glasses get fogged up and they're burdensome. How do we interpret that? And I think that's also important. And I'm not sure what the healthcare sort of structures of healthcare here is, but working within bioethics, I think it's important to realize that concept of burden and what is burdensome is also heavily sort of permeated in Catholic religious sort of ethical directives. And you might say, why is that important? 1 out of every 6 hospital beds in this country are in a Catholic institution. And they are obliged to follow the ethical religious directives of the Catholic Church. And even within, at the end of life, the concept of burden. If something is too burdensome, you don't have to say what that is. You don't have to articulate it, but a patient can say it is too burdensome, and therefore it is appropriate, even within Catholic bioethics, to stop treatment at that point. So it's an important thing that idea of burdensome or burden is important to realize is a very real thing. Because patients have the right to stop treatment. We expect when we do informed consent, they're agreeing to treatment. We must also give them the same right to say, I don't want treatment, or I want to stop treatment. And we have to think about what devices we have and the ability to stop it. It is very different. Like I could choose to take my pills or not. I could choose to drive myself to dialysis or not. But there's some things that we don't give patients the right to stop their own treatment. Or if they did, it would be so agonizingly a way to die. I mean, you could disconnect yourself from your power supply and your VADs, but you don't know how to silence your alarms. And that would be a pretty horrific and anxiety-provoking way for you and your family members to have you die, if you think about that. So there are ways that we, as a profession, have to really enable and empower patients to have autonomy over themselves. So I think we have to think about then VADs, going back to thinking about life-sustaining treatments and what our role is in helping patients stop life-sustaining treatments is important. And there are a number of ways to think about it. One of the biggest constructs out there has been creating a set of binary distinctions, looking at first internal, external as a distinction of life-sustaining support. So the classic internal sort of idea of a life-sustaining treatment would be a pacemaker, distinct from an ICD, but a pacemaker is a form of life-sustaining treatment, completely implantable. The classic archetypal external would be a ventilator, both life-sustaining treatment. Many people find the idea of turning off pacing therapies as unethical. They feel uncomfortable doing it, versus I think most physicians are comfortable with the idea of disconnecting a ventilator. The only difference really is that they are one's internal, one's external. Because then you think, so the internality, externality is not sufficient to say you can or cannot ethically disconnect life-sustaining treatment. So then we think about what it does. Is it regulative or is it constitutive? Meaning, does it completely take over the functioning or does it regulate? So a pacemaker regulates. Pacemaker still relies on intrinsic electrical depolarization. So doesn't take over all the electrical depolarization of the heart. So even that, it doesn't take over. And you have regulative versus substitutive. A renal transplant would be a substitute. We're completely substituting a disease organ with a new organ. Dialysis just regulates. It regulates the sort of biochemical milieu of the patient, but it doesn't substitute for it. And it's external. So this is a way that bioethicists have talked about thinking about life-sustaining treatments. I don't know how helpful it is for clinicians sort of on a practical level, but this is out there when people have talked about it. But I think it's important to realize that these artificial distinctions that people have placed, whether something is completely internal or external, are very different. I could say an internal replacement, such as a mechanical valve, is a very different thing, because that is a constitutive replacement. We would never talk about removing a perfectly functioning aortic valve in someone. The harm to benefit, of course, is astronomically in one direction. That is a very different thing versus something that we implant that regulates, doesn't take over. Putting in an LVAD doesn't take over the pathology of the heart. The pathology of the heart still exists. We are making it perhaps superfluous, except for the right ventricle, but we aren't completely replacing it. So I mentioned before, this is really talking about LVADs, not total artificial hearts. That would be a completely replacement device, so that is a different ethics related to it. But I think to think about how the devices we give to patients, how they may appreciate it and how it leads them to think about end of life issues, I think is important. Because I think what we have with these chronic diseases is we have a dis-ease talking about it. We don't like to talk about it. We don't like to think about end of life, especially for people we've given LVADs to. We've already plucked them from the throes of death once, and then we have to talk about it again. We don't like to do that. We don't like to admit our own fallibility with respect to the successes or failures of our treatment. But I want to just briefly go back to the consensus about withdrawing life support, because I think it's important to realize that the ethical and legal consensus now is that withdrawing and withholding are the same. They feel distinctly different. I will absolutely give you that. But ethically, legally, if you withhold therapy, meaning not offer therapy or choose to withdraw it, they are absolutely the same from an ethical legal standard. And if we give patients the right to consent to something, we also have to give them the right to refuse or the right to stop treatment. That's important, but it's also a relatively modern idea. Many of you in the room grew up with that being just the way it was. But for people who have been around a little bit longer, it used to not be that case. And I just want to go over sort of two foundations that have given us, at least in Western medicine, this is really Western medical ethics, where autonomy is paramount. This is the history of what happened. And so in 1975, Karen Quinlan went to a party. She had a couple of G&Ts. She took a couple Valium, and she went back home. And she was found by someone later unresponsive. She was resuscitated, and about 3 weeks later was determined to be in a persistent vegetative state. And her parents at that time requested that the hospital take her off a ventilator. They thought that it was extraordinary care, and they thought it was causing pain. And they wanted the hospital to remove her ventilator. The hospital, the physicians refused to, because the local prosecutors in New Jersey said that they would prosecute those physicians for murder, actually homicide, that they would take them to court and say, you killed this person by removing her ventilator. And it went all the way up to the New Jersey Supreme Court, because the hospital actually sided with the family. And the New Jersey Supreme Court said that patients had a right to self-determine their care. And patients or surrogates could decide whether or not you could determine the extent of care. And so the hospital eventually, and the physicians agreed to withdraw the ventilatory support. Her family did not actually push for artificial nutrition hydration. So while the ventilator was withdrawn, she actually lived until 1985 because she was continued to get artificial nutrition support and didn't actually need the ventilatory support. And then it wasn't until 1990, which was not that long ago, that the second case that really sort of created the foundation for the ability to have sort of self-determination of care was the Nancy Cruzen case. She also was a young woman. She was in her mid-30s. She was in a car accident, was ejected out of the front seat, ended up face down in a ditch of water. She was found without vital signs. She was resuscitated. And again, about 3 weeks later, she was determined to be in a persistent vegetative state. And at this point, her family really wanted them to stop her artificial nutrition hydration, knowing that this would actually allow her to die. By not hydrating and not giving her nutrition, she would ultimately die. And this was really important because this went all the way up to the US Supreme Court, and it really set the precedent for having a higher sort of evidentiary standard of preferences and wishes. So the crucial aspect of this case was she had told a friend at some point, I would not want to live if I could not live a life that was at least halfway normal, meaning she didn't want to be supported by life-sustaining treatment. And it was that the fact that she had voiced this opinion beforehand made her preferences sort of like this is what she would have wanted. This is why when anyone comes into a hospital, we are legally obligated to say, do you know about advanced directives? It's because of this case that we have allowed advanced directives, living wills, for example, to have such a sort of preeminent role in Western medical ethics, certainly in this country. So these are important because it wasn't until we had these that physicians actually had protection against turning off life-sustaining treatments and patients being able to say, I would not want to be maintained in a vent facility with a trach. because of these. So I think it's important to understand the background because that gives us a much broader ability to talk with patients. And the fact that now the understanding is that when we are removing life-sustaining treatment, we are removing what is now a burdensome treatment for that patient. So we are removing something that is burdensome. Whether or not they're actually experiencing pain from it is it could be a psychological burden. But the whole purpose of removing and discontinuing life-sustaining treatment is that we are impeding their natural process of dying and that we are actually, in fact, causing some type of harm by continuing it. But not everything is equal, of course. So these are a couple of interesting studies done sort of over 2 10-year periods of time looking at LVADs, going back to LVADs. Now, 92% of cardiologists surveyed would agree that an LVAD is a form of life-sustaining treatment. But again, this is about 10 years ago. People view that very differently than they do artificial nutrition hydration, vasopressors, or mechanical ventilation. So, and there was a distinction between the US and European colleagues, which is, I think, interesting. We could sort of think about why that might be different. But there was significantly higher discomfort with the idea of turning off an LVAD compared to turning off a ventilator, withholding artificial nutrition hydration, or stopping inotropies. And certainly 33% of sort of general cardiologists felt that there was different. More recently, this study was published, and I think this is a fascinating study because they looked at providers who take care of people with LVAD. So they range from APPs, bedside nurses, to attendings. These are people who are actively involved in the care of LVAD, so they understand what it's like. And they gave 2 sets of populations, people supported by dialysis, people supported with LVADs. And then they said, we have 3 situations. You either have an acute illness in the ICU, multi-system organ failure in the ICU. You have a new diagnosis of terminal pancreatic cancer, or you're just tired of living with whatever it is, with your dialysis or tired with the LVAD. So those are the 3 clinical scenarios. In each case, the patient themselves was asking to stop therapy. Not a surrogate, but the patient themselves were saying, I want you to stop. And if you look at the difference, people were much more willing to stop for dialysis under any situation than for LVADs. People were clearly much more willing to stop therapy if it was for an acute event or terminal cancer, but not for just this treatment is too burdensome. So there is still even now the idea that you as a patient cannot determine what is too burdensome for you or not. I think what is alarming in this is that 9% of people said even if a patient who has capacity could say, I don't want to have my LVAD anymore, please turn it off, wouldn't honor a patient's wish to do that. And I think that reflects our discomfort and our distress with doing it, which I think is very real, and we have to address that. But I think that this is a modern sort of survey of how things are in the States. And it's important because we have people living longer with LVADs. 75% of people who have an LVAD die in the hospital. That means physicians and providers are necessarily involved with VADs and people dying with VADs. They have to, they're in the hospital. What's interesting is if you look at cardiologists versus palliative care specialists, cardiologists say you have to be actively dying. If you think of a VAD as being a form of life-sustaining treatment, they are actively dying. We are just sustaining their life. And that may be why only 2% of palliative medicine doctors think that you have to be actively dying from some other, the implicit thing is that's from some other cause, not your heart failure. That's making you actively dying. And 60% of cardiologists are comfortable with deactivation. I would say that's probably a high estimate compared to 92% of people who are subspecialty palliative care. And I think it's important that in 64, so 60 years ago, the president of the American Society of Artificial Internal Organs, which is about dialysis, VADs, all sort of plasmapheresis actually even, gave in his presidential address, he acknowledged the fact that we do not like talking about deactivation. It is so unpleasant, we avoid it, but yet ultimately it must always arise. Anything that has an on-off switch is powered by a battery. At some point, we are going to have to turn off or choose not to recharge the battery or replace the battery. That is by nature of the fact that it is an artificial organ. So what does it mean to die on a VAD even? And it's really hard if you look at the literature to actually figure out what that means. Like what does death on an and LVAD mean? So this is a recent study, sort of a focus on LVAD's therapy. And if you look at the different causes, and the table 3 main is the main paper, the stuff next to it is actually in the supplementary material looking at older population. You have withdrawal of support in 16 to 21% of patients. And this, I think the assumption is, although it's not clearly stated in the paper, that this is withdrawal of support to allow the patient to die. Because you could argue if someone comes in with a neurologic dysfunction and they die of that, are we waiting for people to progress to a brain death sort of criteria before we turn off the LVAD? Probably not. So even in our literature, we don't do a great job of defining what it means to die in an LVAD. When we turn off a pump, is it to allow them to die, or is it truly that do they meet neurologic criteria for death? And therefore, we are just withdrawing life-sustaining treatment as we would for any other declaration of neurologic death. But I think it's important to realize that if you have the death compared by era, it's been about the same, but we have certainly withdrawal of support as an important part of how people die. And there's only been really one study that I could find really looking at this. This is a study out of ANOVA, and that they just talked about their patients who came in and had their LVAD deactivated in the hospital. And the blue color is the people who died their index hospitalization, so they never made it out of the hospital. So I think if we look at the yellow and the red, those are people who managed to go out of the hospital, came back in, and eventually had their LVAD deactivated. And I think it's important to realize that all of the sort of major reasons, bleeding, we know it's going to happen. They came in acutely, they were bleeding. That's a known complication. Infection, driveline infection, that's a known complication of having an LVAD, right? Heart failure, we know that's going to happen. Stroke, we know that's going to happen. So the foreseeable reasons or complications are all the reasons why people are actively having or requesting to have their device deactivated. Now, you also have sort of failure to thrive in general. These are the 30% of people not living well. And then, of course, dementia as people get older, maybe multi-infarct dementia contributing to that. So I think it's important to realize that all of the known complications lead to reasons why patients might find an LVAD more burdensome and we might want to deactivate therapy. So how can we prepare better to do that? This is some work that I did together with people at Penn and at Yale looking at how to deal with it. And it gets into a little bit of forming of life-sustaining treatments. And there's certainly different algorithms or plans you could go to figure out how to involve different teams. Palliative care is certainly important. Capacity assessment, weighing the terminality, what is prompting you to do this. Also to address the moral distress, being at the bedside, not wanting to do it. It is absolutely okay and ethically supportable, absolutely, if you don't feel comfortable doing it, to bow out. Your obligation is to find someone who will help the patient in that case. You can't abandon a patient in that, but you could recuse yourself. Certainly, there are hospital structures that allow people to have someone else take over that role. That's absolutely important to do, but you still have to take care of the patient. So I think what we can focus on is how to improve that. So we've done a great job with technology, with the sort of the hemocompatibility of dealing with patients. What we haven't done a good job is looking at the psychological stress and the burden of living with LVADs. And I think that's where we need to spend a little bit more attention. And I think as studies are coming out, looking at more patient-reported outcome measures, looking at life with LVADs, I think we'll get more information about this. I think what's important, there are these two decision aids out there, one from the Colorado group, one for the Methodist group. And I think if we better prepare patients, we clearly know in surgical studies that if you prepare patients and give them a realistic expectation, there's a 30% chance you're going to come out of this operation on dialysis. If someone ends up on dialysis, while they may not be thrilled, they're like, yeah, I told them about a third of a chance. They accept it. They're more resigned. They're more comfortable with that outcome. So can we better prepare people for, if they're getting a VAD as a bridge to transplant, saying, you should just anticipate this is durable. You're not going to get transplanted. What can we do to make your quality of life better with it? How can we make you understand when a complication's happen? How's that going to affect your life? How do you want to respond to it? So I think that looking at this aspect might enable us to improve the quality of a life with an LVAD and actually improve all of our comfort with patients if they say, this is too much for me now. Because you will know they would have thought about it. It will be sort of a self-reflective process. It's not an acute in the act of sudden depression, a situational depression, but a more realistic outcome. So I think this is where we can improve that sort of liminal life with a VAD. And I think this is where a lot of the research in LVAD care is now going. Because I think living with a VAD is in this sort of liminal existence. You are both supported by life-sustaining treatment and not. You are living life or existing. And with that, I will end. Thank you.
Wonderful talk. We have time for questions. Any questions? I knew Keith would have one, so we'll go there first.
I thought that was a spectacular talk. Thank you so much.
Thank you.
One comment, I'm curious as to what the 8% who don't think that LVAD is life-sustaining therapy think it is.
Yeah, I don't know.
I think we all do something proactive before people get mad. What life can be like for that. And then you discussed what to do with HDL and where you're doing something that's more reactive when patients are manifesting concerns about what their life is like at that point. And I'm wondering whether we shouldn't be doing something or structured in between, because to help people, because I think a lot of the people when they get to that point are, it's really emotionally wrenching to get to that point and to know, like, is it okay to feel this way? Is it okay to talk to my physicians about it?
So I absolutely agree with you. So one of the benefits of having started a program is that, I said I need a palliative care person truly to be part of our program, not to just check off the box. And so our palliative care doc actually meets with patients at scheduled intervals. So beforehand, meets with them at 6 months, at 12 months, and anytime in between if we need, but we'll address, so that they have a relationship. Now, I also believe that heart failure cardiologists should be comfortable with primary palliative care. So I'm talking about secondary palliative care. I mean, like furosemide is palliative care, nitrates are palliative care. It helps symptoms, it doesn't help the underlying physiology. So we all should be comfortable. But I agree, and having structured conversations at set intervals makes it a normal part of life. It's sort of like, okay, this is an LVAD, okay. I have a gentleman who's been supported with an HVAD now, so it's an HVAD. He got it pre-Harvey. I learned in Texas, everything is by a major event, so I understand now. It's like, so pre-Hurricane Harvey, he got his LVAD, so that was 2017. He's now got progressive Parkinson's. He's got a chronic driveline infection, so we're starting to have conversations about, like, if your HVAD stops, do you want a pump exchange if you make it into the hospital on time? And I think the older, 2 years ago, he was like, definitely yes. Now he's not sure. But we have these conversations when it's not actively alarming and dysfunctioning, so that I'll have a better sense of knowing, or do you want dialysis? So I think absolutely to your point, we have to be better about it and get over our discomfort about talking about the fact that at some point we're going to have to turn it off.
We got away from involving palliative care early because we had Ellen Hummel. Right. And we used to, in Minnesota, we worked with Keith Sweat. And it was at the beginning of the course, of the LVAD course, rather than at the end of the LVAD. But I agree. I don't know that there's funding all the time.
No, so I'm lucky because I have a just integrated part of our program.
Working either. Oh, wow. Thank you for the talk. I was just curious how you think about for a patient if an LVAD is burdensome to them and you assent or you then turn it off. Does that affect if you would keep them on the transplant list or list them on transplant? And how do we understand those two things?
I'm not quite sure.
So if a patient decides ultimately that the LVAD is too burdensome, wants to stop treatment with an LVAD, how does that impact our understanding of their placement on a transplant list, for example?
We were actually talking about that a little bit earlier. So, I mean, if they wanted us to turn off their LVAD, they, realistically, they're going to die within a certain number of days. So they would not be able to probably get a transplant. If they were a bridge to transplant, I would probably say then we need to inactivate you. I was talking about, the exceptions now when people are trying to get, extended statuses. And, having to review them, there was this one patient who kept coming up and like, patient would rather die than get an LVAD. And my response would be like, deny, the patient then can die. I mean, and I don't mean to be cavalier about that, but someone's unwillingness to say that this is what the publicly vetted, accepted standards are, someone's willingness not to do it. We allow autonomy, but we only allow autonomy to the point it doesn't harm others. So by saying that I'm going to keep this unless I don't meet criteria other than I just don't want it, like who wakes up in the morning and says, I want to get an LVAD? I mean, really? So that should not increase someone else's harm, if we think about it. So I think there are some things which are clearly patient preference sensitive, and there's some things which are medically directed. And we need to use our medical judgment and our society guidelines and rules of governance and how to play fair in a world where we have too few organs and too many people. I don't know if that sort of answers you. Okay.
Idea of functional utility then play into choice? I think it's a similar question.
It is a similar question.
This idea of functional utility, right? So you have a person who says, I can't have a VAD because my life revolves around
swimming,
being on a boat, right?
Mm-hmm.
So does that then, should we take that in?
I think we should take it into consideration. So, but they may have to wait longer. They may have to wait as a status sport for years. I mean, the question is that enough for me to say, let's bring them into the hospital, whether, like they meet the shock criteria, fine. They've got, they're 2 weeks on their balloon pump. They haven't been transplanted. Them not wanting to have a VAD, it's unfortunate, but I would say, fine, you could wait here, supported, you're going to be a status 6, which is what the guidelines say you should be. Because again, your own desire to go fishing, although I would say go fishing, just don't fall out of the boat. I mean, I've had patients with LVADs that had complete immersion baptism because they wanted to. And I'm like, we'll wrap you in saran wrap and hopefully God will prevent you from getting a driveline infection.
Thank you so much for that talk. It really was quite eye-opening as somebody who is involved with a lot of LVAD patients. One question I had for you is for the patients who specifically struggle with mental health after their LVADs implanted. Have you noticed, I don't know if there's literature on this, in the context, whether it was their LVAD was placed in their index hospitalization and they weren't expecting it, and now they're dealing with significant PTSD and mental trauma from that, versus patients who've had progressive talks with their cardiologist for months and then choose to go on an LVAD,
right.
Does that, I would anticipate that would impact the level of mental health burden, but I don't know if it's.
I agree with you. I don't know if that's been teased out as much. I mean, a lot of the psychological burden I think people are unaware of what it is, or maybe that, a patient family will say like, I'll be there. And then all of a sudden they disappear. I think it's important. To your point, I strongly believe that if we're going to put in a durable LVAD, we should have primary person consent and not family surrogate consent. I mean, I have a patient who's just transferring care back to the VA who we saw initially a number of years ago. He did not want to have an LVAD. I'm like, fine, we don't have to give you an LVAD. I will help take care of you. However, he ended up in outside hospital, critically ill, intubated. The family was like, give him an LVAD. So he has an LVAD. Now he has buyer's remorse. He's coming back to the VA. He doesn't want it. And talking about it with his family there, he'll talk about it. And his daughter, unfortunately, will be like, oh, no, he's fine. I'm like, he's clearly, be quiet, leave the room and let me talk to him. So I think primary person consent is incredibly important. The problem, to some extent, has to do with reimbursement and billing. If someone comes in and you put them in a balloon pump or an Impella, and then you have to think about, okay, they're failing, what do we do next? Hospital can charge for one pump. They've got to eat the cost of everything else. So if you're going to go from something to a semi-durable pump, maybe allow them to rehab, assess their mental status, make sure, do you really want this? The hospital has to eat the costs, which is unfortunate. I think it's an unfortunate reality that I think we as a community, sorry, haven't seen Nicole in a while. I think it's an unfortunate situation that we as a community could maybe try and say, like, this is not fair. We are not respecting our patients. But I agree. I think people who are prepared, again, it comes to do with like they may have a better idea. I think a lot of it is body image, and having the drive line and what it does to sexual activity, sexual intimacy. When you have a drive line sticking out, where do you put it? Having conversations about positions is something that none of us are really trained to do. We just get better at it. So I think that's part of it.
I have one random question. So as a general cardiologist, I don't have too much intersection in the space anymore, but it almost sounds like establishing some of these goals that patients have before they end up in the scenario kind of would be a great place to make changes and prevent some of the, functionally futile placements. Would you suggest that as general cardiology and preventive medicine, we, for the higher risk patients who may have risk factors you foresee, whether it be a family history or a lot of coronary disease, and you get that spidey sense they may eventually have heart failure and have an acute event, should we have these discussions or at least broach the subject ahead of time?
I think so. Yes and no. I think primary, care doctors, primary sort of first level service providers should be able to have these conversations. I think with heart failure, it's tough because I think it's important to have an idea that this is coming down the road. If someone has systolic dysfunction, to realize you have a life-limiting disease that's worse than most cancers. We do a horrible job of getting that point across. So I think having the discussion about, you need to think about what your goals are, do you have a wedding to get to in 6 months, in which case inotropes are going to be better than doing a VAD or a transplant because you're going to be in rehab, But I think for anything where there's a possible tertiary quaternary option, having the first discussion, then sending them to someone who could then say, this is the reality of what it is important. Now, I've had patients who, I had a patient who I've added who, we were talking about transplant, whether or not she wanted, she kept smoking. She was like smoking 1 cigarette a day. And I'm like, why can't you stop smoking 1 cigarette a day? She's like, I don't want a transplant. I'm like, you don't have to get a transplant. Just stop smoking 1 cigarette a day. I mean, that's bad for you, but like, that should not be the reason why you're smoking. But, we just like had this total disconnect that she thought if she met the criteria, I was going to transplant her. It's just a patient I thought I got along well with. I thought we were open. Apparently, I was not very clear in what I was saying. So I think the more people hear it, the more they're going to realize, like, yes, I better take my meds and I better follow what I'm supposed to and make good choices about, do I want like that fried chicken or the baked chicken, whatever it is.
Well, we're at time. Thank you very much.
Thank you. Thank you.